you. So as Dr. Seedy said, we went to nursing school together. So I've been a nurse for over 20 years, graduated from this program back when it was still a 3-year diploma program in the late 90s. My nursing career has taken me, I started in the era where you had to have experience to get a job. That was once a time, like there wasn't a nursing shortage. So I worked in long-term care, subacute rehab, worked in administration, was a director of nursing for a number of years, supervisory positions, and the past 10 years, while raising my children, finishing my bachelor's degree, my master's degree, I've worked at an acute rehabilitation hospital with brain injury patients, stroke patients. I was on the stroke unit for 9 years. I work currently on a unit that is mostly a lot of post-op bilateral knees. They're there for acute rehab, pain management, and I have lots of experience in GI issues with my patients. So it really doesn't matter where you work in nursing, you're going to have to deal with bowel, constipation, diarrhea. It's all something that will come in contact, whether we're in the ER, med-surg, peds, oncology. But we really need to break the stigma because nobody wants to talk about it. It happens in the bathroom, it happens behind the closed doors, nobody discusses it. So we need to be able to feel comfortable walking into a room, never meeting a patient. A lot of times I'll walk in and say, "Hi, my name's Becky, I'm your nurse till tomorrow. When was the last time you moved your bowels?" "Oh, I have a suppository for you." Like, it's great icebreaker. I have no idea, probably what your last name is, I don't remember it, but I know when you moved your bowels. So we need to find out from our patients what's their history. Maybe their norm is to go 4 times a day and they haven't gone in 2 days, so it's abnormal. Maybe, I actually worked with a nurse who, when she was in nursing school, went to anatomy and physiology class and learned about the whole bowel system, constipation, diarrhea. Didn't realize that the fact that she was having diarrhea 5 times a day wasn't normal because she never talked about it with anybody and nobody ever told her. So a lot of times it happens behind closed doors, nobody shares. So education is very important. A lot of the medications to treat constipation, diarrhea are over the counter. So they don't need a prescription for it. They can just go, they see something on a commercial, they go and buy it. They also misuse it. They took 2 doses and they're still having diarrhea and they're taking more and more, and they can become toxic and have symptoms from that. And we always want to make sure that we tell our patients they should follow up with a practitioner. Maybe they need to see a GI doctor, maybe they need to have an endoscopy, colonoscopy, see what else is going on. So today, our objectives are, from your weekly guide, to identify the indications, actions, effects, interactions, and contraindications of antidiarrheals, laxatives, and other GI drugs. And then we will be applying the nursing process, what our goal is every day, to take care of our clients, receiving antidiarrheals, laxatives, and other GI drugs. So just a little bit of background. The bowel, the small intestines, it's going to absorb nutrients. The large intestines, that's where all the water is reabsorbed. The bowel movement is formed, and then we can pass it. We have to look for reasons that can impact absorption. Medications, if they've had a bowel resection, if they're missing half of their colon, their stools can be looser. They also might have, we need to look for etiologies, things. There we go. We want to look for symptoms that they may have. They may have a tumor. So we can give them all the medication that we want to help them move their bowels, but if they have a blockage, it's not going to go. If they have an infection, then that needs to be treated. If they have an acute appendicitis, we can give them medications for this abdominal pain, but that's not going to help them. They're going to need surgery to have their appendix removed. So the etiology of constipation, it's normal or slow bowel movement to the defecatory dysfunction, or both. Our textbook says less than 3 bowel movements in a week is considered constipation, but again, you have to talk to your patient. I've had patients that say they only move their bowels once a week. So to me, that's definite constipation, but for them, it could be completely normal. So it often occurs with the weakening of the defecation reflex due to voluntary control of the anal sphincter preventing defecation. There's always been a time where, oh, you get that sensation, but you're not in the right time or place, so you hold it, and that can lead to further issues. Other issues that impact constipation: acute illness. It takes a toll on the body. Decreased movement, poor appetite, and meds. I mean, how many times post-op patients were given tons of narcotics, and that just slows everything down. And then their movement is decreased, their appetite is poor, so they're just getting hit with a trifecta of issues, and their bowels definitely should be on the forefront. Can't tell you how many times I get new admissions that are 4 days post-op, and the last time they moved their bowels were 3 days before surgery. So then, where they should be worried about motility and getting up and moving and having their pain under control, I'm trying to get them to move their bowels. There we go. So manifestations. When I think of constipation, like, just what this picture's doing. I'm holding my gut, I don't feel good. It's the infrequent defecation. Everyone's different. Again, you got to talk to your patient, find out what is normal for them. 3 or less bowel movements per week. If they're straining, moving their bowels, incomplete evacuation of stool, if there's a sensation that there's still pressure that they need to move their bowels, if the bowel movement is hard, and if they need manual evacuation, they're all signs of constipation. And again, it's just that feeling, that overall, feel terrible. That's good. Some people writing. Okay. And on the opposite spectrum of constipation is diarrhea. So it's almost like a Pepto-Bismol commercial that we're doing. Constipation, diarrhea. So the patho is increase of liquid in the stool and increased frequency to greater than 3 days. There are patients that can have multiple bowel movements a day. Doesn't mean it's diarrhea if it's formed, but there are symptoms caused by increased bowel motility, secretion, retention of fluid, and/or inflammation or irritation. You got to investigate the cause. Talk to your patient. We'll talk about that with the etiology, what could have caused them to have these symptoms. Big thing with diarrhea is we need to push fluids. We need to watch for fluid volume shift. If all the fluid is rushing to the bowel, where's it leaving? It's leaving their vascular system. They can be dizzy, hypotensive, high risk for fall because they're running to the bathroom and then they're feeling dizzy as soon as they stand up. So a lot of things can be going on with these patients. Manifestations, they can have acute, chronic, mild, severe. It's frequent semi-liquid and semi-liquid stools. A lot of times it's self-limiting. You get the stomach bug. We've all had it. 24, 48 hours, if we're lucky, it's done, gone. Can be associated with fever, vomiting, bloody stools. So the big thing in nursing, we wear lots of hats. So then we get to play the investigator. Try to figure out what could be causing our patients to have diarrhea. Are they taking too many laxatives? They were constipated, now they're taking tons of laxatives and they can't figure out why they're having diarrhea now. Stop the laxative. Well, nobody told me I had to stop it. They just told me to take it every day. So again, a lot of education is needed for these patients. There could be lack of digestive enzymes, infection with a virus, bacteria, inflammatory bowel disorders, irritable bowel syndrome. Meds can cause diarrhea. I mean, it's a side effect. When we talk about a lot of meds that we'll be giving to treat these things, they're the side effects of the meds as well. Antibiotic-associated colitis. So somebody has an infection, we're giving them an antibiotic, and now we've given them colitis. C. diff is a common one, and now they have to battle that and get more antibiotics. Stress. I mean, how many tests? You guys had a test this week. Clinical, you get that feeling in your stomach before you go into that situation. Hyperthyroid, bowel resection, and HIV/AIDS. All can be reasons for diarrhea, but if you're not talking to your patient, it might be a simple fix, but it might be something you didn't realize that they were out of town. I had a coworker, her daughter went on a mission trip to Colombia, came home and was sick, and she brought a parasite home. but it took like 4 months for them to figure out that it was right after she came back from her trip she wasn't feeling good. But it just took a lot of investigating. All right, so we're going to go to your prototypes, and we'll go through the medications. So the treatments for constipation, the first one, Valium, Metamucil, what does that do? Yeah, so it bulks. It helps form the stool, help with peristalsis, move things along. What are some of the things that we want to watch for, like adverse reaction?
Floating.
Yep. Anything else?
Esophageal or bowel obstruction.
Yes, because this can bulk the stool if they're not, especially if they're not taking in enough fluid. You got to make sure that they're hydrating. With the psyllium, it can block them up. It can do the exact opposite of what it's supposed to be doing. What are some of the nursing considerations that we want to remember with this? Yep. Push fluids. Anyone else have anything else?
1 hour before, 2 hours after other meds.
Correct. You want to take it 1 hour before, 2 to 4 hours after, because it can affect the absorption of other medications. Is this something that you would take quickly if you're severely constipated and you want something that's going to work fast? Is this the drug of choice that you would offer? No. This takes like 12 to 24 hours. Can sometimes take a couple of days. It's something you would take longer term than some of the meds to help with your bowels. You also want to make sure that we talked about the increasing fluid, increased exercise, movement, high fiber diet. Anybody have anything else? So the next drug is Escalona, so it's a stimulant. What does this do? What action? Right, pulls the fluid into the bowel. What type of things do we want to watch for as far as adverse reactions with this med?
Nausea, vomiting.
Yeah, so some of the things that are symptoms anyway can be compounded by taking this med. What type of nursing considerations do we want to have? First, we'll talk about PO, so oral bisacodyl.
You said no milk.
Right, no milk. Do you know why?
Says it decreases the gastric pH and then it messes with the enteric coating on the drug.
Right, so you're not going to want to crush this, you're not going to want to chew this, you're going to want them to take this whole, and really all it does, it just breaks it down earlier in the gut, so it causes increased symptoms. But it's definitely, they're already feeling yucky because they're constipated. You don't want to add to that because the med's breaking down earlier in the system. So any other nursing considerations before I jump in?
Take on empty stomach.
Yes, that's what I was just going to say. A lot of times they say take it at bedtime. So where I work, we'll offer it, I work night shift, I'm offering it at bedtime. Do you want it at bedtime? Hopefully that'll work by tomorrow morning before you're in physical therapy. Is this something you're going to take quickly? The oral. We're still talking oral. Yeah, it's not going to be immediate, like 6 to 12 hours, so overnight, and they should be able to move their bowels by the morning. Hit most of that. Again, we're going to increase fluid, high fiber diet. What about suppository? Did anybody write anything down about the suppository form?
The 15-minute action?
Yes, so it's quicker. 15 to 60-minute action. When you're administering it, you want to make sure you're administering the suppository finger length along the side of the bowel. Pushing it up in the middle in the bowel movement isn't going to do anything. It's not. The bowel it'll melt and it will absorb and it will stimulate the action. A lot of times we use,
I was just going to say, can you explain that one more time? I was still writing.
so when you put the suppository in, you don't want to just push it right into the stool. You want to push it against the bowel wall so that it helps with absorption. Our spinal cord patients, they're on bowel protocols. It's a Dulcolax suppository every other night before their shower. It's evening, and it keeps them regular. And it's not an issue. They don't need a ton of other meds, and their body's able to regulate with that. Mag citrate. What is the action of mag citrate? I heard somebody say it. Increase the osmotic pressure. It's going to retain water, going to distend the intestines, and increase peristalsis. What are some adverse effects of this? Definitely can affect fluid and electrolyte imbalance, absolutely, because you're pulling all of that fluid into the gut. Is this something that's slow acting? Is this fast? This is something you're going to take fast. So it usually works within 30 minutes to 6 hours. So when you're giving somebody mag citrate, you want to make sure anybody that's working in your area knows to watch for that bell to help them safely get to the bathroom. Because when they got to go, they got to go. Adverse, we're going to look for nausea, vomiting, diarrhea, which is what it's supposed to cause. Elevated magnesium levels, watch for CHF with these patients. One of the side things, it tastes terrible, so giving it cold on ice makes it a little bit more palatable for these patients. Fall risk is a big thing, because again, they get that urge, and it's not something that they can wait for. So whether it's safe for them to walk or not, they're going to get up and they're going to try to go to the bathroom to prevent being incontinent. And you want to take it as prescribed. It's not something that people should be taken to do a colon cleanse, you know, on a Sunday night. It's, people do it.
Oh, I'm sure.
Oh, they do. A lot of times it's a part of
You read it on Pinterest.
Oh, of course, yeah. How to lose weight, and a lot of times it's a part of a bowel prep before endoscopies, before colonoscopies.
Oh, is that what magnesium citrate is?
It's that little.
It is.
It's like
Is
a little
that
green
bottle
bottle,
white?
like it looks like soda.
Oh, it's
is-
the one that looks like
yeah,
soda,
it looks
not
like-
the white
No.
thing before.
But this, it works pretty quickly. I mean, I've had patients that basically take it, put the cup down, and walk into the bathroom. But everybody's reaction to it is a little bit different.
Are you able to mix it with something since it tastes so bad, or no?
Typically, you don't mix this, and you're going to want to take it as fast as you. It's not the worst of the worst of bowel meds, but it's cold and chug it down. It's like a ginger ale, I think is what they say, or like a Sprite or something like that, but still not the greatest,
Yeah, I don't believe you.
right? I'm not trying.
I'm not going
It's optimism. Ginger ale spray.
Yeah.
I'll take one for the see you guys, I'll report back.
And the last med for constipation is sorbitol. And it's not necessarily a med that you're going to give for constipation, but it's an additive in a lot of medications that you can administer, and it's important to know the effects that it can have on the patients. So what does sorbitol do? Right, pulls water back into the intestines. So again, it's not necessarily given directly. Dr. CD and I were looking up some facts this morning, and there was an article that said 60% of liquid drugs have sorbitol in them. Well, how often do we give liquid drugs? A lot. You know, imagine the patients that are, you know, have feeding tubes, and we're throwing everything down a tube, and we have bottles that we're just pouring into a cup to pour down. What effects could it have on that patient? And it wasn't until she mentioned it this morning that, you know, a lot of people, you always hear, oh, they're not tolerating the tube feed because now they're having diarrhea because I just started their tube feed. Well, it has nothing to do with the diarrhea. It has to do with all the meds you just gave and the laxative effect that it has on those patients. So it's just being aware. What are some adverse effects of sorbitol? Right? Diarrhea. weight gain, the fluid and electrolyte imbalance is prevalent across all of these medications. Hyperglycemia, because sorbitol is in like the gum. Do you ever hear, don't give it to the dog because sorbitol is bad for your dog? But it's in sugar-free gum, so it makes it sweet. So nursing considerations?
Did you say hypo or hyper?
Hyper.
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 Hyper. Wait, you're right.
Glycemia, elevated blood sugar. What are some nursing considerations we would have for sorbitol? You want to administer as prescribed. There are patients individuals that abuse laxatives. So this is an easy, take a little drink of this. It's a little sugary sweet shot, and it's going to clear you out. These patients are fall risks as well because they're going to get that sensation that they've got to go, and if you're in with another patient, they're going to get up and try to go to the bathroom, whether they're safe or not. We're not going to share it with other individuals, measure it accurately. A little bit goes a long way. And then we're going to watch for signs and symptoms of elevated blood sugars if patients are taking higher amounts. So now that we've got the patient going, and it's always a fine balance. When somebody's constipated, you're giving them tons of bowel meds, and then it's the opposite way. Just got to even out. But so you have a patient with diarrhea. We have a couple of medications that we can use to treat them. The first is the diphenyloxylate with atropine sulfate, Lamodal. What is the action of Lamodal? So it's going to slow everything down. It's a scheduled 5 drug, so usually it's probably locked, has to be counted. You need a script for this. It's not something that you can just go and buy at the pharmacy. What are some side effects? Absolutely. Absolutely. You want to watch for changes in CNS. Look for anticholinergic side effects, elevated heart rate, dizziness, headache, flushing, nausea, vomiting, dry skin, dries the mucous membranes out, can cause urinary retention. We also want to watch for decreased blood pressure and respiratory rate, especially if someone's taken more than what's prescribed. And that's a big piece right there, because a lot of times Lamodal's written, take 1 tablet after each loose stool, a maximum of X amount a day. Well, the person misses the X amount a day, and they're having diarrhea 2 or 3 times an hour, and they're just taking the pills, so it's at a higher risk for overdose almost. What are some nursing considerations for these patients?
They might be a fall risk because of the CNS.
Absolutely. Maybe they shouldn't be operating heavy machinery. Probably shouldn't be drinking alcohol. Not that I would think you would with diarrhea, but you never know.
It's different.
Right now, we're lit.
So there's acetylcholinesterase inhibitor medications used for myasthenia gravis, certain diseases, and it can decrease the effectiveness of Lamodal if they're taken together. What type of education should we provide for these patients? I'm going to make sure they're taking it as prescribed. Go ahead.
Start on the rice diet.
Right. Bland, like a brat type of a diet. Increasing fluids because they're losing so much with the diarrhea. Take the medication as prescribed, so if you can only have 4 or 5 tablets total a day, make sure you're not going over that because there can be other symptoms. Yeah.
What was that diet you said? I didn't understand that.
Like a brat diet. bananas, rice, apples, toast.
I'm pretty down the rice diet.
Yeah. Can cause dizziness, drowsiness, so we really don't want them doing anything that would require them to be alert. We don't want them to exceed the maximum daily dose. And if they're having some of those symptoms, dry mouth, maybe a hard candy would help with those symptoms.
They mentioned hand washing too.
Yes, definitely hand washing. With any of the diarrheas, hand wash, right? Because a lot of those bugs, the sanitizer does not kill. So hand washing is, C. diff is one of them. Hand washing is always the best. Hopefully you have gloves on when you're dealing with it, but hand washing is always the best line of defense. All right. Loperamide, or Imodium AD. I'm sure we've all seen commercials, seen things in magazines. What does this do? Right. It also slows down the GI, and the big thing with this is it has similar effects. It's not a narcotic, so there's not the CNS side effects that the Imodium has.
Let's ask how that breaks down up there. So, diphenoxylate with
Atropine sulfate, that's one medication. These are both opiate-related antidiarrheals.
Two there.
Correct.
Okay.
Correct. They're both under that drug class. And this one's related, it's a cousin, but it's not, it doesn't have the opiate in it. So it doesn't have the CNS side effects. It is over the counter, so anybody can go and buy it. What are some of the adverse effects we should watch for with this drug? I hear noise, but I couldn't hear.
I'm sorry, abdominal pain, constipation, nausea, vomiting.
Yep. Fatigue, drowsiness. What if somebody's taking too much? What are we watching for? More cardiac, right. Can cause arrhythmias, torsades de pointe, like a VFib, cardiac arrest, death, which you're saying that's kind of crazy. But again, if somebody's having chronic diarrhea and they're taking more and more and more, they have a higher risk of becoming toxic. So, fluid shift, again, with this as well. Are they dizzy? Are they tachy? What type of nursing consideration? We're going to watch for those fluid volume shifts for these patients. Again, they're having the diarrhea. And usually it's more than just a 1 or 2 day dose of episode of diarrhea when these patients are reaching for some medication to help with the symptoms. What should we be teaching these patients?
Hydrate.
Mm-hmm. Definitely. Push fluids. Got to replace everything that they're losing. Take recommended dose. You don't want to take, I'm having really bad diarrhea today. I'm going to take 2, and it only told me 1. You don't want to do that. Should really only take it 2 days, 48 hours. And then go see a healthcare provider if you're not having relief. Because again, maybe they're thinking it's something innocent and they really have a parasite or they really have something else going on systemically that this isn't going to treat. Refrain from operating heavy machinery, still probably shouldn't be. Hand washing, again, any of the diarrhea, you definitely want to do that. Follow up with your healthcare provider. And then if they're having I think that's the one where we put constipation stuff on that didn't go on. I'm like, wait a minute, how does that tie in? All right. The last 3 are adjunct antidiarrheal meds. First one, the cholestyramine. You guys covered this when you did your cholesterol meds, Questran. So you've already covered that a lot. The big thing with that is making sure that you're not taking it along with other meds, taking it an hour before, 2 to 4 hours after, so it doesn't affect the absorption of other medications. And I was here for the class where you learned about that for cholesterol, and the only time I've ever given it is for patients that have had severe diarrhea, and it was a way that we helped treat it. I've never given it actually for cholesterol.
And I'm the exact opposite.
Yeah.
I'm giving it for cholesterol. I'm never giving it for diabetes.
So it really just depends on what caveat of nursing you end up in, because you'll see these medications used in different ways. Next is the octreotide. What does that do? What's the action? It's, yes, it's, decreases the GI secretion and the motility, absolutely. What would we be using this for? Like what type of patients? Because again, this isn't one that you would necessarily see in every caveat of nursing for diarrhea. Pardon?
Immunosuppressed patients?
Yes, so HIV and AIDS patients, certain intestinal tumors, these are like compromised patients that you're going to be given this. A GI bleed, you need to slow things down. Diarrhea that's resistant to other meds, this can kind of be like a last resort type of a medication. What type of adverse effects could these patients have from this med?
Cardiac arrhythmia?
Absolutely. Most common is bradycardia, decreased heart rate. Also could have some headaches, worsening of diarrhea and gas, which is kind of crazy because that's what we're using it to treat. Elevated blood sugars. This is something that's given in an injection form, so could be injection site pain for this patient. And then there have been some shortness of breath and respiratory infections that we're seeing in these patients. What type of nursing considerations do we need to, I mean, how are they getting this medicine? If it's an injection, how will they get it at home? I mean, it's a deep muscle. It's not like a little sub-Q like insulin, or, I mean, it's a deep muscle injection. So we want to make sure that the patient or a family member is confident and knows how to properly administer the medication. What other teaching?
Tweak meals.
Well, this is an injection.
Online
Is that what it says?
From the book, yeah, I have between meals to prevent fat malabsorption.
What does it say?
It was talking
Between
about
meals? I don't remember that.
Between meals.
We'll double check on that.
Yeah, definitely.
I had never injected an deltoid.
Mm.
Has to be deep muscle.
Deep muscle, yeah, so thinking thigh. Monitor blood glucose for these patients. Look for signs and symptoms of injection site infections. We want them to take it as prescribed. And we're going to look for signs and symptoms of issues with their gallbladder and pancreas, because you want to use it cautious with any patients that have pancreatitis, gallbladder issues, biliary colic. So their symptoms could worsen. And last but not least, Creon. I like that better than the trade name. Cold drug. Right, what does Creon do? It's a pancreatic enzyme that replaces lipase, amylase, and protease to aid in digestion of fat, protein, and sugars. So when you're looking at this, and I will refer to the trade name, that pancreolipase, it's an ACE. So what do you guys know about ASE ending? It's an enzyme. So it's going to help in digestion with food. So what type of adverse effects does this have?
There wasn't really anything in the book on this, to be honest.
Right? We
cheated a bit.
Yeah, we looked elsewhere. So some of the adverse effects that we have are skin rash and hives, bowel blockage, diarrhea, nausea, vomiting, abdominal pain, headache, hunger, thirst, urinary frequency, blurred vision, dry mouth, having like fruity breath because of the ketones, sweating, weight loss, what type of contraindication did you guys get for this one? We found this on our exploration. Don't give, it's a pork derivative, so if somebody has a pork allergy, this is not a drug that you would want to use for those patients. What type of, yes?
So what type of patients would you generally use this on?
So this is going to be that they're having issues with their pancreatic enzymes. They need to replace it to help, because they're having diarrhea because they're not able to absorb fats, proteins, sugars, so it's just passing through them very quickly. So you're going to stop.
With a pancreas issue.
Correct.
Okay.
Correct. Typically. Not to say that they wouldn't use it for somebody else, but that's typically what. Now, what type of nursing considerations do you have for this? So since it's an enzyme, when would you want to take this? With the food, because you don't want to take it 2 hours before you eat, or you want it's going to help to break down that food. We're going to watch for any GI side effects. Is it improving with the use of enzyme? And if somebody's going to be on this long term, they might add a little bit of allopurinol. You guys got that a couple weeks ago, because it'll help with prevent damage to the kidneys from long-term use with uric acid crystallization. So that is a side effect. So to prevent that, we add another med. What are we going to teach the patient? You're going to take it as prescribed. Make sure you're taking it with adequate food and meals. One of the things we saw when we were looking it up, so if a client is overeating and eating lots of meals and snacks, you don't want to go over the daily recommended dose. Just because you're eating all day long doesn't mean you should be taking this med all day long. And then we're going to assess their bowel movements to see if there's improvement with the addition of this drug. So to change it up just a little bit, instead of doing a little case study, we're going to do a little quiz. It doesn't count, but it's in format with some things. You may see items like this on your boards, or tests, or just give you a little idea. Yeah. How are you guys making out? You ready? All right, so we'll go through them together. Number one, which comment made by a client would indicate to the nurse that a client needs further education regarding treatment of constipation? Well, if you read it, so we had 2 people that actually read them all correctly. Read letter A. there's a typo. So they would, so if they're only drinking 8 ounces of water a day, it's not enough. So C was supposed to be the answer, but there was a typo in the question.
Didn't make any sense.
Yeah. So we want them to drink like 8 ounces as long as they can tolerate cardiac wise. But yes, I should take my bisacodyl tablet with morning with my cereal and milk. No, because then you're going to have increased GI symptoms, bedtime, empty stomach is what we want to take that for. Number 2, which medication would be appropriate for a client to use for bowel preparations for surgery? Select all that apply. A and C, yes. We don't want to give B because that's for treatment of diarrhea. And D, it's really usually just an additive that's used in conjunction with other meds to stimulate moving their bowels, or it's used as a filler in other liquid meds. Number 3, which client is contraindicated for use of magnesium citrate? B. A client presenting to the emergency department with abdominal pain. Why? Right, we have no idea why they had that abdominal pain, so it's not until they've had testing to make sure it's not a tumor, it's not acute appendicitis, and that it is truly constipation, then we would treat with the mag citrate. Number 4, the diphenyloxylate with atropine sulfate would be contraindicated for use with the following clients. Select all that apply.
A, B, E.
A, B, and C is why they would be contraindicated. So A, we want to use it cautiously with patients with kidney and liver issues because it can increase risk of hepatic coma. B, if a client's getting antibiotic, they have antibiotic-associated colitis, diarrhea can be therapeutic. It's the body's natural way to get that infection out of the body. And clients receiving the acetylcholinesterase inhibitors, it can decrease the therapeutic effect of the drug if they're taken together. And number 5.
One quick question.
Yes.
Why would you take a constipation medication and a diarrhea medication at the same time?
Oh, you wouldn't normally, but there are patients that do it.
Okay.
They do it. They don't realize what that med is for. Because think about it in the community, they're taking it. Their doctor told them 6 months ago to take this med. They don't realize what it's for. Now they have these symptoms, and they're taking something else to counteract the symptoms.
But as not being contraindicated because we're trying to balance, or?
Yeah, because I think it's S and I because we put E as well.
Like as a nurse, you want to give them both.
You wouldn't
Why do you
give
get
them.
both? The patient's being treated with it, so you would be like.
You wouldn't give it. You wouldn't give Lamodal if they're being treated with mag citrate. You want them to have diarrhea. So that's why E would not be. Would be contraindicated for the following clients. Well, it's not. I wouldn't necessarily say it's contraindicated. Yeah. Yes. I'm sorry. I didn't realize that's where you were going with. I mean, it's not. I'm giving you mag citrate because I'm doing a bowel
You're not going
prep
to say
for.
dumb on the NCLEX?
No,
Which is the dumb
The
answer?
textual Of course, you could be like, oh,
I'll
that's
distinguish the two. I
my
got it.
second year in
You
nursing
can do it,
school.
it's just stupid.
Mag citrate is dumb.
What did you say was the increased risk of hepatic something?
Coma
Coma.
The renal failure.
with the renal failure patient.
Yeah, we got it.
I'm good on that one. Am I dumb answer? All right. What nursing observation of a client with diarrhea would cause the most concern? A, the bloody diarrhea. We did talk about that it can be common if they have like an acute GI upset, it can fever, bloody stools, but it still is something that could be worrisome. If somebody's taking Questran, that's what we want it to be an hour before meds and meals. A client who reports a headache with the octreotide, that is a side effect, so sometimes we deal with the side effects. And a client who states they should refrain from driving when taking Villamodal, absolutely, because it can affect the CNS. Any questions? All right, I'm going to turn over the class to the opposite side, to Dr. Seedy, who's going to finish up on